Our next presentation is shifting gears. We're going to hear from Dr. David Sunderman-Oft, DSO, who's CEO at Modality.ai. He'll be presenting on an innovative multimodal speech biomarker approach for monitoring ALS disease progression. Welcome.
Well, thank you, Fernando. It's great seeing you. It's great seeing you all on the call today. Thanks for the opportunity to present, and I'm actually co-presenting with our senior research scientist Hardik Kothar, who is going to dive deeper into the ALS data. But before doing so, I'd like to give you a little bit high-level information about what Modality does, because we're different from many of the other presentations today, because we're not a therapeutic company, but we are a diagnostic company. We are addressing one of the major pain points, however, that therapeutic companies are facing, which is that many of the drug trials fail, and that's to a significant degree due to the fact that assessments are very difficult to accomplish. If you may remember Matt Dermott presenting at the ALS meeting in June, and he talking about the fact that 97% of the phase 3 studies of the last 30 phase 3 studies have failed, and not really clear whether it is because of the drug not working or because the trial's not working. One of the major pieces is, of course, that we use ALSFRS-R as the primary endpoint, and some of the more exploratory measures, such as digital endpoints, are now becoming more of the center of attention. As you have heard also, James Barry and Jeremy Scheffner during their presentations yesterday. So the premise is that when you use digital endpoints that are actually inspired in our case by what a typical clinical assessment of the ALSFRS-R would look like, you have a potential of stronger, more sensitive, more responsive measures, also ones that you can bring to people's homes. And I'm going to explain to you how that works. So again, ALSFRS-R usually an assessment that happens in the clinic. Some remote assessments can be done that way as well. You have a scale that is being conducted, and certain questions are usually being asked that then result in the filling out of that survey form. What we do at Modality is we replicate that process by having a virtual guide, Tina, that you see here. Many of the patients that are on the call may have already experienced talking to her in one way or the other, because we have many ALS studies today. And so what happens is actually that Tina, the virtual guide, interviews patients in a similar fashion as a speech-language pathologist or neurologist would do. So she asks, for example, to describe pictures or repeat certain sentences or do a diadokinesis task. She also asks patients to describe their problems in their own words. So we basically measure how patients function and also how they feel, because we do ask about their most bothersome problems, which we do analyze as well. So their speech, their language, their facial movement, their body movements, their cognition, as well as really how they feel. And that is being delivered to anyone's own device. I was talking about in clinic. No, we usually do it direct to participant on their own device, your smartphone, your iPad, your laptop, anything that's web connected. It has a webcam, microphone. Pretty much any device that is connected to the internet today is compatible. We don't require you to install software, so that all works directly through the web. The only thing that happens is you receive a link in an email, for example, you click on the link, and the next thing that happens, you talk to Tina through the web. So that is basically how that works. Significant operational advantages, specifically in the conduction of clinical trials, which is the sole focus of the company. Supporting clinical research. So no special hardware, no special software, works on any device, as I mentioned. You don't have to remember any password or credentials as a patient, which is a significant hurdle often. And of course, for the sites, it's also a very easy to actually administer through our dashboard and other ways. We're working with big pharma, biotech sponsors, specifically in ALS and Parkinson's disease. These are a significant portion of our attention. We are also funded and supported by the federal government. National Institutes of Health have supported us with multi-million-dollar grants. We are partnering, a very strong partnership with the Veterans Administration as well, and the Michael J. Fox Foundation that was mentioned just now as well, also with over 30,000 of their patients have actually worked with us before. Very scientific entity. We will hear from Hardik Kothar today about some of our ALS work. Over 100 publications by now. We on many studies, almost 40 studies, observational studies. You see breakdown here, observational studies, interventional trials, as well in over almost 150 sites by now in all around the world, 17 countries, 5 continents, many languages that Tina speaks. So she's actually being translated into all the different Spanish and French and German and what you can think of, and almost 80,000 participants in studies have used Tina to date, which really provides a significant feedback loop also for us to improve the systems. We are on version 40 by now, so it's really easy to use. How is that possible? We are very multi-centered team. We have experts from artificial intelligence like myself. Believe it or not, but I've been in artificial intelligence for 25 years now, in machine learning, and have led own companies, led R&D divisions in industry organizations. I was a full professor of computer science and published over 200 papers and books and patents in that space. So that's how old AI is. We have, of course, people from clinical science, from operational backgrounds, from technology, from entrepreneurial background, and over actually 7 PhDs in the company that do the scientific evaluations and running the trials, actually. Hardik is with us today. He's going to talk more about the specific science, and I'm going to hand over, speaking of him, to him right now.
Thank you, DSO. Yeah, thanks for setting the stage for me to talk about the science. So DSO mentioned that Tina measures how people function and feel, how patients with ALS function and feel. And the way we do that is through objective measures. Objective measures like the timing of speech or pausing or respiratory capacity, which measures how the motor speech is functioning. Facial movement like jaw velocity, acceleration, which is also a measure of the motor speech. Tina also captures how patients feel through the patient report of problems. If you look down there, that's the task, a standard set of tasks that we use to capture these measures. Our system is very configurable. It depends on the study, so we can add tasks, we can remove tasks, but these are the standard tasks that are used by clinicians today and have been used for many decades now. If you go to the next slide, I'm going to talk about how these objective measures extracted by the conversation with Tina are responsive and sensitive. When I say responsive, it means that we can measure a clinically and statistically meaningful change in patients with ALS in as little as 4 weeks in bulbar onset patients and as little as 9 weeks in non-bulbar onset patients. And I'll talk more about that in the next slide. But these measures are also sensitive. And when I say sensitive, they measure a clinically, statistically significant change even before a change is reported in the ALS-FRSR speech score. So if a patient thinks that their speech is fine, there has been no change, and keep reporting the same score on the ALS-FRSR speech score, it's not that there aren't any changes happening to them. These changes can be captured by objective measures extracted by the conversation with Tina. Next slide, please. And this is an example of one of the objective measures. So the canonical timing alignment, which measures intelligibility, you'll see this graph over here. The x-axis is days since onset, and the y-axis is the measure CTA, which goes from 0 to 100, where 100 means a good score, a 0 means a bad score. You'll see that the bulbar onset patients shown in blue, there is a steep decline in this measure, whereas for non-bulbar onset patients, the red curve is not as steep, but there is still a change happening over time. This is a growth curve model which helps us measure a clinically important change, that is a change that is greater than the minimal clinically important difference in as little as 4 weeks in bulbar onset patients. Next slide, please. Now, we get asked this question a lot by people we talk to. If these objective measures are responsive, how many patients do you need to measure this responsiveness? And we answered this exact question. So these graphs are examples of some of the measures where the x-axis is the sample size and the y-axis is responsiveness in weeks. And you can see that responsiveness is pretty robust, even with smaller sample sizes. Of course, the confidence interval increases the fewer people you have. If you have, say, 10 patients, you'll see larger error bars, but it's pretty robust, especially the first graph on the left, which is the canonical timing alignment I talked about in the previous slide. Next slide, please. If all of this is happening remotely, you'll say, how good is the data, right? So we measured this. We saw that the data quality, that is the audio and video quality, is pretty robust, even for people, for elderly patients, even from rural populations. I think thanks to the pandemic, everyone has a device that is connected to the internet, has a good webcam and microphone, which is actually helping us collect this really important data remotely. And we also see that the adherence is pretty good. So do patients do what they're required to do for the task? And we saw that the adherence is around 98%, which is excellent for data of such kind. Next slide, please. Now, what are the takeaways? So we can extract objective audio-visual biomarkers remotely from patients with ALS. These objective measures track longitudinal changes which are associated with disease progression. Some of these metrics can detect clinically relevant changes in as little as 4 weeks. And these measures are responsive even with smaller sample sizes, up to even 15 patients. These measures also detect changes before any changes on the LSFRSR speed score. That is, they are granular enough to detect a steady change. With this, I want to point you to this journal article published this year, which dives deeper into all of the things that I talked about. I welcome you to read that. And with that, I think we are ready to take some questions.
Yeah, thank you, Hardik, for the scientific deep dive, and just to wrap things up, you have seen a few snippets of the work in ALS research we've done. We have, I think, almost 25 publications by now in ALS specifically. So when you go into our website, Modality.ai, you will actually be able to download and read all these publications. And ALS has been at the core of our mission at the company since the beginning. We were founded 6.5 years ago and have been working with Jordan Green at MGH and many others in the community ever since. And so it's a pleasure and honor for us to present here at ALS ONE once again. Anyway, as Hardik said, very happy to take questions and keep this conversational.
Thank you, DSO. Thank you, Hardik. There's one question so far in the chat, and I have one as well. The first one, it's from Dr. Ben Brooks. What measurements are specific for palatal speech? And so my understanding, palatal speech is the speech where your tongue makes consonant sounds, right? So for others listening, please.
That's a great question. We don't have any measures for consonant speech per se, but we do measure acoustic vowel space, which basically measures tongue movement. And we have seen that acoustic vowel space in patients with ALS is reduced, and we can actually track that longitudinally as well. Yeah, I hope that answers the question.
Thank you. I had a question myself. It was really interesting, the slide where you presented the data for the people who had bulbar onset versus people with non-bulbar or limb onset, presumably. Thank you. And my question is, relating to the folks with non-bulbar onset, there is that early decline that you're still detecting. How specific is that to ALS? And if it is relatively specific to ALS, is there potential that that's diagnostic?
Excellent question. So we kind of answered this question indirectly by looking at controls, healthy controls for whom you shouldn't be detecting the change. So there can be something like a learning effect where they're doing the task and they're kind of learning how to do the task more efficiently. We saw that this decline in non-bulbar patients is even steeper than any learning effect in controls. So we did see some decline in controls, which wasn't statistically significant from statistically different than 0. But of course, the non-bulbar onset curve was different from the curve for the controls. So it is probably specific to ALS, the change that you're seeing. Regarding diagnosis, I would leave that to the clinicians. Of course, it takes around 9 weeks to detect a clinically important change in this population, which I guess is good enough to help with diagnosis, not the sole measure, but yes, to assist with it.
Yeah, at the same time, you can talk a little bit about our experiments around, for example, distinguishing different subgroups of the populations. Like we have run significant experiments around building classifiers that use the multimodal measures as features to actually distinguish, for example, between healthy persons and ones that have limb onset, for example, versus the ones that have bulbar onset. And so you can have a very strong actually opportunity to actually tell these apart. We are not currently marketing ourselves for diagnostic purposes, even though we are listed with the FDA. We could technically be used in clinical care as diagnostic aid, but that's not our focus as a company. We exclusively work in clinical research right now. Hardik, if you want to talk a little bit about our results in published results actually in classification of different groups.
Yes, so we have also looked into stratifying fast progressors and slow progressors. We'll actually be presenting some results at the ALS MND conference next month. So if you're attending, please come see our poster.
Thanks. And that actually relates, I think, to a question that's been asked in the chat here. So on this, speaking specifically to this figure, the x-axis is in days since onset, and many of these are very long, right? Very far out. So some of them would equate to about 20 years. How certain are you on the diagnosis, I guess?
Right. So we did this work in association with EverythingALS, and that's where we got the diagnosis from. I know they seem like outliers, so we actually did the same analysis by excluding these participants who seem to be outliers, and there's no change in the results. So we decided to report it with them included.
And these are just a few, right? That are like further out.
Yeah, a couple of them.
The bulk load, of course, of persons are shorter in their onset, luckily there is a few people that have really slowed down in their progression and are still, available to report after 20 years.
Right. I just want to point out these are non-bulbar onset patients, so probably they're on a different trajectory. Not sure.
Well, thank you both again for a great presentation, and again taking the time to answer our group's questions.